We cannot
Good,
see.
good evening, Dr. Pandey. I think he looks like Anirban Home Chaudhary. I think he used the link. I think same link.
Oh, is it? Okay, okay. Oh,
No,
yeah.
no.
Hi, Rajesh.
Pandey sir is there.
Yeah,
But
Rajesh is there. I can see
he's
him.
muted.
Yeah, good evening, good evening. Welcome to the Delhi team. Justin here.
Rajesh is muted, I think.
Muted, I think. So 3, 2, 1, you tell me, we will start. Once attendees have joined?
They're joining.
Yes, we are joined.
Just one more minute, if you don't mind.
Okay. Ready? Can we start? Welcome, friends. Welcome to this new episode of GICS Rapid Journal Review. It's always been a long-standing question that whether mild targeted hypercapnia can actually improve neurological outcome after out-of-hospital cardiac arrest. And this is what has been the research question for the recently published TAME study that we are going to discuss and dissect today. Tonight, we have amongst us, in the panel, Dr. Rajesh Pandey, Chairman of Critical Care at BLK Max Super Speciality Hospital, New Delhi. We also have our regular panelists, Dr. Pradeep Rangappa from Manipal Hospitals, Bangalore, and Dr. Ajit AK from Whitfield Astor Hospitals, Bangalore. And tonight, it will be presented by Dr. Shaunak Pal from BLK Max Super Speciality Hospital and moderated by Jitin Sharma, Dr. Jitin Sharma from the same hospital. Welcome all the panelists and the presenters and the moderators. We now move on straight to Shaunak to start his presentation.
Thank you, sir. And a very good evening to everyone present over here. So, I hope the slides are visible.
Yes, please go ahead.
Okay, sir. So today we will be presenting a review on the targeted therapeutic mild hypercapnia after resuscitated cardiac arrest, which is also known as the TAME study. The principal investigators of this study were G. Eastwood, A.D. Nicole, and other TAME study investigators. And the study was published on 6th of July 2023 in New England Journal of Medicine. So the paper that came in New England Journal of Medicine was titled Mild Hypercapnia or Normocapnia after out-of-hospital cardiac arrest. So what is the significance of this study and why is this study important? So rushing through the concepts that most of us already know, these are the chain of survival in out-of-hospital cardiac arrest patients. We are aware that the steps of resuscitation go through early activation of emergency response services, immediate high-quality CPR, early defibrillation, early advanced cardiac life support, and advanced post-cardiac arrest care. So the components of high-quality CPR are like starting CPR as early as possible, minimizing interruptions, chest compressions of 100 to 120 per minute, compression depth of 2 to 2.4 inches in adults, and a breathing rate of 1 breath per 5 to 6 seconds, and allowing chest recoil after each compression. So in spite of all these measures, we find, and the authors mentioned in their study, that cardiac arrest continues to be a major cause of death and disability. Hypoxic ischemic encephalopathy is a major cause of morbidity and prolonged hospital stay. Even after achieving return of spontaneous circulation, cerebral hypoperfusion may continue due to the autoregulation present in the cerebral uh, vascular environment. So brain hypoperfusion might lead to cerebral hypoxia, exacerbate the brain damage, and lead to poor neurologic outcome. Partial pressure of arterial carbon dioxide, as we all know, is a major physiological regulator of the cerebrovascular tone. Hypercapnia can increase the blood flow by up to 2 millimeter per 100 gram of brain tissue, with each increase of 1 millimeter of mercury in the partial pressure of carbon dioxide. The international guidelines recommend targeting normocapnia in adults with out-of-hospital cardiac arrest who have been resuscitated and are being cared for in the ICU. However, normocapnia may be insufficient to restore and maintain adequate cerebral perfusion. So, we need to know what is the existing evidence in this regard. So there are a few studies, some observational studies and one RCT, which have been done previously to delve into this topic. So this was an observational study that was published in Resuscitation Journal back in 2013. So it was arterial carbon dioxide tension and outcome in patients admitted to the intensive care unit after cardiac arrest. So we found that hypo and hypercapnia are common after ICU admission post cardiac arrest. So compared with normocapnia, hypocapnia was independently associated with worse clinical outcomes. However, hypercapnia was associated with increased likelihood of discharge of patients from the ICU. In this study, they actually used the discharge criteria as a surrogate of positive and favorable neurological outcome. Another observational study that came out in Critical Care Medicine Journal back in 2014, it studied the arterial blood gas tensions after resuscitation from out-of-hospital cardiac arrest and its associations with long-term neurological outcome. So in this multi-center study, hypercapnia was associated with good 12-month outcome in patients resuscitated from out-of-hospital cardiac arrest. But the investigators were unable to verify any harm from hyperoxia exposure because they were also checking the effect of oxygen concentration. So they said that further trials should focus on whether moderate hypercapnia during post-cardiac arrest care improved outcomes. There was another study which was published in Resuscitation Journal. This was a prospective observational crossover study, which studied the impact of hypercapnia on cerebral oxygenation in mechanically ventilated early cardiac arrest survivors. And they used the NIRS technique to study the cerebral oxygenation. They did find a positive association of hypercapnia as reflected in the increase of cerebral oxygenation as measured by NIRS, but there was they did not have any statistical significance in the same regard. Now, probably only randomized controlled trial which actually tried to study this topic was the CCC trial. This was published in 2016 in the Resuscitation Journal, and it concluded that in cardiac arrest patients admitted to the ICU, targeted therapeutic mild hypercapnia was feasible, appeared safe, and attenuated the release of neuron-specific enolase compared with targeted normocapnia. They basically use neuron-specific enolase, which is a known biomarker of cerebral injury, to assess the positive or negative effects of hypercapnia on the patients. Though the study was not designed to find a statistically relevant effect of hypercapnia on positive neurological outcome. So on the backdrop of all these studies, basically these studies gave way to the investigators to come to their research question in this regard. So the research question was that can targeted mild hypercapnia improve neurologic outcomes at 6 months as compared with targeted normocapnia in adults who have been resuscitated after out-of-hospital cardiac arrest. So the TAME study was an international investigator-initiated open-label and randomized trial. The inclusion criteria was patients who are more than 18 years of age, patients who have suffered out-of-hospital cardiac arrest, of presumed cardiac or unknown cause, and sustained return of spontaneous circulation, which was defined as a circulation that was sustained for more than 20 minutes without chest compressions. The exclusion criteria was an interval from ROST to screening of more than 180 minutes, any unwitnessed cardiac arrest, or any limitations of care. So randomization was done by means of a web-based system. Whenever possible, patients were co-enrolled in the TTM2 trial. Enrolled patients were randomly assigned in 1:1 ratio to targeted mild hypercapnia and targeted normocapnia groups. Attending physicians were aware of the intervention assignment, but the assessors uh, were the ones who were assessing the neurologic outcomes were not aware of the intervention. During data analysis, the statisticians and authors were unaware of the intervention assignments. Patients were assigned to targeted mild hypercapnia while maintaining a PSO2 of 50 to 55 millimeter mercury, or to normocapnia group, where PSO2 was maintained at 35 to 45 millimeter of mercury for a 24-hour period beginning at randomization. Deep sedation was maintained to achieve the RAS score of -4. Assessment of ABG was done every 4 hours with no adjustment in blood pH for hypothermia in view of hypothermia. Use of end-tidal carbon dioxide levels by clinicians to guide was used by clinicians to guide ventilation management during the intervention period. The ventilator settings, sedation, and use of paralyzing agents were at the discretion of the treating clinician. So, as I said, the patients were divided into two broad groups of mild hypercapnia and normocapnia. So, in this study, 829 patients were enrolled in the mild hypercapnia group, and 839 were enrolled in the normocapnia group. So, the primary outcome was a favorable neurological outcome, which was defined as a Glasgow outcome scale extended score of 5 to 8 at 6 months. The secondary outcomes were death within 6 months, poor functional outcome defined as modified Rankin scale score of 4 to 6, and patient perceived health-related quality of life, which was assessed using a visual analog scale. So this is the Glasgow outcome scale extended score that was used to assess the favorable outcome. It ranges from 1 to 8, with 1 signifying death and 7 to 8 showing good recovery. The modified Rankin scale score, which was used to assess the poor outcome, ranges from 0 to 6, with 6 denoting the dead patients and 0 with no symptoms. So the authors, coming to the statistical analysis, the authors calculated that enrollment of 1,624 patients would provide 90% power to the study. So sample size estimation was based on earlier trials of mild hypercapnia. 1,700 patients were enrolled in the study to allow for withdrawal of consent and those patients who were lost to follow-up. All the analysis were performed in intention to treat population. Binary outcomes, including the primary outcome, were analyzed with the use of generalized linear mixed effect models with a binomial distribution. Adverse effects were compared by means of chi-square tests. Survival analysis was performed with the use of Cox proportional hazards model. The complete case analysis were performed in pre-specified subgroups with respect to the sex, age, time from cardiac arrest to ROS, initial cardiac rhythm, whether they were shockable or non-shockable, and the presence or absence of circulatory shock on admission. Statistical significance for the primary outcome was determined within an alpha level of 0.05. Analysis were conducted with the use of SAS software version 9.4 with R software of version 4.0.235. Coming to the results, the study period spanned from March 2018 through September 2021. 1,700 patients were enrolled from 63 ICUs in 17 countries. 847 patients were enrolled in the targeted mild hypercapnia group. 853 patients were allocated to the targeted normocapnia group. The baseline characteristics were found to be comparable in both the groups, and the incidence of adverse effects was found to be similar in both the groups. So this is the graph showing the carbon dioxide intervention in both the groups. As we can see in both the graphs, the separation in mean partial pressure of carbon dioxide values occurred over the first 4 hours of intervention period. So beyond that, till the end of intervention period, the difference in the mean PaCO2 levels remained constant between both the groups. So these are the primary and secondary outcomes. As regard to the primary outcome as well as the secondary outcomes, it was shown that there was no statistically significant difference between both the groups. The primary outcome of favorable neurologic outcome at 6 months was found to be 43.5% in mild hypercapnia group and 44.6% in normocapnia group. So the p-value was not significant. Similarly, even in secondary outcomes, the poor functional outcome at 6 months, death at ICU discharge, death at hospital discharge, as well as death within the 6 months were found to be almost the same in both the groups. So, both, as I just said, the favorable neurological outcome at 6 months was 43.5% in mild hypercapnia group and 44.6% in normocapnia group. And similarly, the death within 6 months was also statistically, there was no statistically significant difference in between both the groups. So coming to the discussion, in this randomized trial, authors have compared targeted mild hypercapnia with targeted normocapnia in adults with coma who had been resuscitated after out-of-hospital cardiac arrest. In previous studies involving humans as well as animals, higher partial pressure of carbon dioxide appears to have some neuroprotective effect, probably due to the increased cerebral blood flow and the anticonvulsant effect of carbon dioxide, which is caused due to prevention of cerebral alkalosis. So differences in cerebral perfusion may affect the neurological outcomes after cardiac arrest. Early intervention to improve cerebral perfusion may attenuate the hypoxic ischemic encephalopathy in these patients. In the observational study done by A.G. Schneider, G. Eastwood, and others, the investigators found normocapnia to be associated with increased mortality. However, hypercapnia was found to be associated with higher number of patients who were discharged from the hospital, as I had shown earlier, and this was used as a surrogate for favorable neurological outcome. The other observational studies studying the association of hypercapnia and improved neurological outcome in post-cardiac arrest patients found some relation with positive outcome. But most of these studies failed to demonstrate any statistically important results. Another observational study from Finland, conducted by the Finn Resusci group, found a good neurological outcome in post-cardiac arrest patients with hypercapnia, but the results were not statistically significant. Investigators from Australia and New Zealand conducted a prospective crossover study using NIRS to measure cerebral oximetry, as I had shown earlier. So even this study was done on very few patients and had its own limitations. The CCC trial was probably the first randomized controlled trial to study the protective effects of hypercapnia by measuring the serum levels of neuron-specific enolase and S100B, both of which are biomarkers of cerebral injury. So the study found a positive association of hypercapnia with neurological outcome, and the patients in hypercapnia group had lower serum levels of both the biomarkers. However, the study lacked the statistical power to show that hypercapnia actually improved outcomes in this subset of patients. So the findings of this TAME study did not support the hypothesis that targeted hypothermia improves neurologic outcomes. It did not improve the neurological outcome at 6 months or the risk of death within 6 months. The distribution of scores for functional outcome was also not better in these groups, as well as the health-related quality of life. There was no statistically significant difference in this regard. So the strengths of this study were a large sample size, pragmatic eligibility criteria, early and effective separation in mean partial pressure of carbon dioxide values, and numerous hospitals and countries which were from which patients were included for the trial. This led to results that could be generalized on any other population. But this study has had its own set of limitations, like except for the guidance on sedation targets, mechanical ventilation, and neuroprognostication, Concomitant care was not specified in the protocol. Hypercapnia was common at randomization and may have attenuated the difference between groups. Trial included only out of hospital cardiac arrest patients of a presumed cardiac or other cause. So results of this study cannot be generalized on other population. The intracerebral pressure was not monitored routinely. So the proportion of patients having already increased intracerebral pressure or cerebral edema was unknown. Follow-up was a challenge in this study as due to the coronavirus pandemic, as a result of which there was a loss of data of 7.6% of the patients. And there was no between trial interaction with the TTM2 trial. So any assessment in this regard may have been underpowered. So that was all that was presented in this study.
Thank you, Dr. Shaunak. Wonderful presentation. And now it is the time for dissecting the study and opening up the Pandora's box. And I wish to start by asking Dr. Pandey. Dr. Pandey, you are there?
Yeah, I'm very much there.
Yeah, the study, as Shaunak has shown in his last slide, looks into out-of-hospital cardiac arrest also by a layman resuscitator or layperson resuscitator in shockable rhythms. So does that largely limit the generalizability of this study?
I think the result shows that, this was applied to a very specific population and the results were not as per the expectations. So I would also like to know what was the age, because the lower age was 18 plus. Was there any higher cutoff days age, Shaunak? Because if you are including very elderly people, say 70 plus, then the results would be different. So I think
they did not have.
They did not mention the upper age limit, sir.
If they had included patients who were, say, up to 65 years, from 18 to 65, maybe the results would have been different. Because if you see, this study goes against the buildup that was happening prior to the study, because most of the data that you showed, which led to the start of this study, was in out-of-hospital cardiac arrest patients. And you showed that mild hypercapnia was beneficial. It increased the cerebral blood flow and the oxygenation. And the last CCC, you showed that the this neuron-specific enolase was, its levels increased. And there was another one, S100, that you showed, another marker whose levels increased. Yes, now, these increased levels, as far as we know, are associated with increased recovery of the brain tissue. But if that is not happening, or if hypercapnia is counteracting that effect, we are not sure. But largely, this was a nicely conducted study. If you look at the numbers, they are huge numbers. Intention to treat analysis, they had a, like you mentioned, separation right in the beginning in the CO2 levels. So the effect of CO2 was profound.
It's absolutely fine that it was a very well conducted study. Maybe with those, but the one important thing, Jitin, I want to ask you: if you look into this study, it had non-blinded enrollment. That is, the attending physicians were aware, the assessors were not aware, the statistician was not aware, but the attending physicians were aware of this enrollment. Now, does that again affect the quality of the study, Jitin?
I think very well, sir. When the attending physician is aware which branch the patient belongs to, it can definitely affect his treatment. When they want to have a positive outcome in one particular group, they may be more interested in changing over the ventilation or looking after other parameter as to the normocapnic group where they were. So definitely, this was one of the limitations of the study where the physician was not blinded, I guess, sir.
Pradeep, a lot of this, yes, Dr. Pandey, you want to add anything to that?
Yeah, although the study was randomized, so the distribution to, either group was by chance, by randomization. But again, like he said, if a particular unit, there was a multi-ICU study, 69 ICUs, if they felt that possibly this is not a good idea to have higher, PCO2 levels, so maybe they were not providing the same amount of care that they were giving to the hypocapnic group or normocapnic group. So I think that bias could be there. I'm not saying it was there, but it has.
Very true. Very true. Pradeep, you can see that although this can be considered as a strength, but if you look at the other way, this study gave a lot of flexibility to the investigators. So there was a lot of variations in the clinical treatment as per their wishes, as per their judgment. Now, again, do you think that this is one of the cornerstones which can be looked upon as a weakness?
Yeah, see, Anirban, I went through this study. In fact, I was hugely critical. The reason is, see, if you look at all the data Saunak presented, congratulations, Saunak, very well presented, because I really want the presenters to dwell into all the pre-existing trials or the backdrop of this trial. So as you rightly presented, if you look at the backdrop of this trial, it was only 2 observational studies and they embarked on doing such a large study, because I worked in Australia. I know how the mindset works. And the second randomized controlled trial, Anirban, with 86 patients that they did, was also by the same author. So the thought process, what I can, I can sort of envisage is, it is like a hypothermic trial, which they had a revelation that hypothermia saves patients. So here also authors had that conviction that they will go on to have this revelation that hypercapnia, because there are enough data. If you look on the contrary, there is enough and more science to say that we have to maintain normoxia, normocapnia, normothermia. So we are in that league. And suddenly authors pondered about saying, okay, we increase the carbon dioxide, cerebral blood flow increases, and then we will have some revelation to say to the world that, okay, this will help. I think that's the sort of a thought process into the study. But there was no robust sort of a science in that sense that hypercapnia is something that is going to really make a difference. And having said that, even authors do acknowledge in limitations, which you are referring to, Anirban. So there is no mention as to other strategies. What was the sickness quotient of the patients? What was the mechanical ventilation strategies they used? And what are the neuroprognostic modeling they used? And what are the types of sedatives? All this definitely
all
would have
this
had bearing,
this would
right?
have
And they
added
had not
more
specified
value.
that.
I agree. I get your point.
So it is a well-conducted study. They put a lot of resources, but I don't think it was backed by a good sort of a physiological studies as a context or a backdrop for conducting such a. There was a lot of resource expended, but we knew that this would fail.
Yes.
So that would be my observations.
Right, Pradeep. Moving on to Ajit. Ajit, as Pradeep has said, that if the authors have acknowledged this point, they have also acknowledged another point, that they did not monitor cerebral perfusion pressures, and we know to study the impact of PCO2 on the brain. Now, do you think that monitoring of cerebral perfusion pressure was something which was very essential to actually draw inferences from the results of this kind of study?
So basically, the introduction itself, the couple of studies which are shown, which I can remember, the triple C study and, the Asher study, initial Asher study, because those studies are the studies which is showing, the hypercapnia is having a better outcome, neurological outcome. But, if you look at the Finnish study, because obviously the hypercapnia was associated with a poorer outcome, there's some kind of a contradiction is happening there. So that basically shows that, you are making it hypercapnic under the impression that because carbon dioxide is a vasodilator, it is going to increase the blood flow. But how is it going to affect the cerebral perfusion pressure may vary from each and every patient. As you rightly mentioned, I believe that probably there should have been some kind of a method where you can monitor cerebral perfusion pressure. That would have been given a more idea about what exactly is happening in these patients. It is not only blood flow is increasing.
Yes, Pradeep.
Anirban, just to add one more, because see, as Saunak presented the RCT, which these authors only did in 2016, they did not show any benefit in any clinical outcome. It's a small subgroup, 86 patients.
True.
They looked at secondary outcomes of neurological functional recovery, mortality. So they did not find any sort of outcome benefit there. I don't know why one would embark on doing so. This is just a science, like Rajesh Pandey is in the higher pedestal of our society. So when such a study is presented to ANZICS, if we are all sitting on this, pondering about the nature of the study, would you agree for such a resource, burdening sort of a study, where the previous studies have not really substantiate the outcome benefit? Is my question to all the leaders here.
Yes. Can I respond to that? See, Pradeep has made a great point. If the research question is unphysiological and we are expecting great results, that is not going to happen. So I think if you look at the conventional way, hyperventilation is not to be done. Normocapnia has to be maintained. So this is what we teach. This is what the majority of the world, as based on the current AHA-ACLS guidelines, is practicing. And second thing, we are talking of bias. So the bias, if the same group of workers who were doing these studies, because most of these studies have one or two common authors in what he showed. I think in all the studies that you showed. So I think I agree with Pradeep that they felt that they somehow need to prove this, that hypercapnia is beneficial, although it is contrary to the physiological, science. So before, and plus they got it published, such a big negative trial in the #1 journal, the New England Journal. So I think long back in 2012, I attended one big, session in SCCM, which was based on the kind of trials that we are doing. So the medical luminary clearly said that we need to choose our questions wisely. We should not go against the normal physiology. So I think that makes
very valid point, Dr. Pandey. But one more point, when you have raised the question of hypercapnia, although this has not been acknowledged by the authors, but I have noted it and I raised by this, that in these patients, upon randomization, both groups had hypercapnia. So when you think that they were randomized and at randomization they are hypercapnic, so do you think that following those results over a period of time can influence because of the normocapnic or hypercapnic management?
It may have an impact. Definitely, yes. Ajit, you're saying something?
Yes. Yeah, that's the thing. So another thing is, the supplementary care. I agree with Anirban that definitely it can have an impact. That is one of the criticism for the trial. And another thing is the supplementary care. See, once you randomize the patient, and once they are in the randomized the groups, the two interventional arm and the conventional arm, basically the supplementary care, whatever the supporting care, what is given is that is left to the discretion of the physician. There is no control on that. So that is also another loophole in this case. If you microscope analyze, that also might have made some difference in the outcome.
And one more point, which also I wanted to Jitin, that this study was conducted at a time when the COVID was at its peak. And if you see that the question of follow-up, these patients were not followed up over a period of time. It was only at 6 months, the neurological outcome. So now do you think that it would have been better? I won't say that this is because it's a circumstantial need, but it would have been better if some follow-up, either telephonic, if not physical, would have made it better, the study?
Definitely, sir. The COVID pandemic definitely made the impact on this study. The follow-up was not done in many patients. But if you analyze that, the group of the people in which the follow-up was not done was equally distributed in both the groups. So I think somewhere that this effect was negated by this equality in both the groups, I guess.
Okay. So besides that, there were some, because they had some missing data and they did not have on how to churn out those missing data. And so that was also issue. But since we are running out of time, I wanted to take some questions from the question answer, which has been posted by the viewers. And I like Jayaprakash.
One question to Saunak, Anirban. Saunak, you saw that the normocapnia had more of hypocapnia episodes. 15.8% had hypocapnia in normo carbon dioxide group. Do you think that may have contributed to the data not coming out significant, or you think it is insignificant? That because it was 15.8% versus 3.1% between the hypercapnia.
So that was a significant difference, but the authors did not mention any difference arising in that regard due to that difference.
They conveniently ignored that. I don't know, but
they did point. So they did point out among the limitations that the incidence of initial hypercapnia was there, which might have influenced the difference between the two groups, the difference and separation of PCO2. But they did not mention anything regarding the hypocapnia part, which was, as rightly mentioned by you, sir, that it was significantly higher in the normocapnia.
Yes, fine.
Could I?
Justin has a question, Anirban.
Yeah, Justin, yeah.
Could I be devil's advocate? Yeah, I will make a comment. So let's, for example, for all practical purposes, this sounds more like a pragmatic, as reasonable randomized control trial as possible, with as many things equal as possible, except the only separation that we see is a CO2, 40 and 50. So that only tells me that actually both groups are the same. Maybe 40 and 50 is not that different.
Very, 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 very rightly pointed out, Justin.
Or that the intervention could have been much higher, like 60 or 70. And the question about the ANZICS being, I don't think ANZICS gives money easily. I understand that they are a big lobby, Bellamon et al. But still, they put in nearly 10 to 12 years of time into this research and probably would have shown enough signal for them to get funding for such a big trial. So I would not negate the simplicity of ANZIC's decision making, but again, like they must have seen the difference, but they could not probably ethically allow 60 plus CO2 as we've seen in the naval studies, and probably that could not have been like practical in a sense. The other way that the other comment
is anyhow not mild hypercapnia, Justin.
No. I mean, animal studies have used between 60 and 100, so that's how they showed neuroprotection.
Yeah, Justin, please continue.
Yeah. So the third point of is that at the end of the day, what I realized is that most of the point that makes that they are hypercapnic on presentation, and the treatment group actually got more attention.
True.
You never know. So as much as we are talking about the therapy not being there, and like Ajit said, the supporting group, actually, when you want to bring the CO2 down, you make a more effort to the patient. And as an intervention, that would drive sort of better quality of care, like how we have seen in reverse trial. Some people get better care.
Justin, I agree with you, but again, you see, what is physiological in the entire neurology and neurosurgery domain is keeping normocapnia. I mean, nowhere are they suggesting that hypercapnia is going to be beneficial. It is normocapnia, and even hypercapnia, hypocapnia is only for a limited period when you have impending brainstem herniation. So I think something that goes outside the realm of normal body physiology, and we are expecting great differences, great answers, possibly that would be slightly contradictory.
Yeah. I agree, Dr. Rajesh Pandey. Yeah, thank you. I think one point. I think generally we see asymmetric lesions in our ICUs, and that's where we were not sure about the autoregulation of the each zone, and hence we are on this side, or maybe we are forced to be on the normal. When the damage is more uniform, like here, physiologically there isn't anything to suggest that the regional differences would be so high. Like Nikhil was messaging, steel or reverse steel phenomena may not necessarily be as important in a global insult compared to regional insult.
Justin, it is very difficult to comment on when we don't know about the perfusion pressures, because this was not monitored in the study, and whether you have a reverse steel or a steel, that is largely dependent on the pressures which are active, because otherwise neuroprotection is the basic issue of compliance in neuroprotection fails to be resolved. So I think that those data was not adequate to comment upon that. But having said that, I want to take the question from Jayaprakash. Jayaprakash was asking a very basic question. Is intent to treat analysis good for this study? Was it the perfect way? And I think that it is a quite possible, a good way of looking into the figures. Yes, Dr. Pandey, intention to treat, was it appropriate for this study setting?
I do not know whether, I feel intention to treat is much better than protocol, because you are including all the patients that you enroll in the study. So there is no selection bias here. So that is how I would look at these studies. His concern may be that, a lot of patients would die, or these are extremely sick patients. Should we exclude out some of the patients? But then that's what I pointed out initially, that the selection criteria or inclusion criteria could have been age specific. Then we could have, excluded those patients who are at the extremes of age, especially the elderly ones.
So probably the comparison would have been better. Between the apples and oranges would have been better. So, but another important point, which also Jayaprakash raised, that is it underestimation of statistical power? I don't think there is any reason to believe, because authors have a very good power. They have maintained an 80% power.
Yeah.
They have a very good large sample size. And
I disagree though. I agree with Jayaprakash. This is underpowered, even though it's a big number, because they're powered for 50 plus 58, 50 versus 58, and the study itself is like 40 versus 43. So technically speaking, it is underpowered still.
Well, that's again too much technical. Probably we will have to take a middle path where we can see
I think let us hear out. No, I don't.
Jayaprakash, can you include Jayaprakash?
Because power is basically to do with all the number of patients based on the previous study. So they are doing PhD in statistics or PhD in intensive care. JP, can you enlighten us? Why do you say, why do you build? Because I thought the biggest strength is the last sample size.
Yeah, please include JP in the group and let him speak.
I think JP must be there. I would want to hear out from JP why he believes this is underpowered. Is JP there?
Okay. Another is a question which has been put by Nikhil is the fundamental question on physiological basis of the study itself. And of course, we have already discussed it, so we are not going to take it further. So if there is any questions, yeah, there is from Swagata asked that there is some benefit from hypercapnia. The pragmatic design would have been easy to do. Well, that is again a good question that I think Swagata can be included in the panel so that she can explain it better. From whatever I can understand from her point is that this design could have been converted into an inexpensive design if they could have shown some amount of hypercapnia also to the normocapnic group. Now, I think that that much of heterogeneity was there and said they could reach the numbers, or else this numbers should have shrunk and they would have come back to the same 200 odd patients from initial 86. Yeah. So can you you have Dr. Swagata also and Dr. JP, if they can explain the reasons for their question in a better way, then it will be easier for panelists to further discuss upon this.
Can we dwell again on the power thing that JP raised? I agree with Pradeep that power has to be based on the, predominantly on the sample size and the discrimination between the two groups. I think they had a clear discrimination between the two groups, the normocapnia or whatever you call it, and the hypercapnic group, as was shown in that which was sustained throughout the study period. So I don't think there would be any issue with power of the study. I would still say that, they should have tested the hypothesis on large-scale randomized animal study, maybe before embarking on this huge human study, because they did everything. You can't have a near perfect study. So you will always have some biases or some issues. So this was a nicely conducted study. That is how it found a place in the New England Journal of Medicine. But I think they were over enthusiastic about their expectations. That is how I would put it.
But
yeah. Sorry.
Another question which was lingering, Saunak. See this ROSC, they did make a mention, because what really determines HIE and the outcome is to look at ROSC, isn't it? So they only said that ROSC, if it is sustained more than 20 minutes, was the inclusion criteria. But was there any, I was just scouting through, was there a mention as to what was the median ROSC, Saunak, in the manuscript? Because that really determines their outcome, isn't it? Functional outcome. But there was no mention, isn't it, Saunak, in the whole manuscript?
As far as I remember, sir, it was not mentioned.
So doesn't that intrigue us as to why they should not mention about the ROSC in two groups? I don't know. It's just a thought that comes very intuitively to me. What do you think, Dr. Rajesh?
That will be a very important point. Very important point. If you look at the eCPR also, we don't include these kind of patients there. So I think more than 20 could mean anything. So we don't know what is the range and what was the average values here. So that may be a determinant, because those who took long time for ROS to be achieved, they would obviously do badly, whatever you do.
More than 20 minutes.
And then ROSC was given in a subgroup analysis. And again, under 25 minutes and over 25 minutes, both groups are more or less the same. They are not really pulling the data on either side. So it's in the subgroup analysis. That's to the answer.
No, can you be more clear?
So from a statistical power point of view, just like most of our sepsis trials, where they are powered to probably 30% mortality or 40% mortality, and we end up seeing 26%, 25%, 20% mortality in the study group, essentially making the study not powered enough, as you expect a 40% mortality. So if you actually power it for 20%, let's say in this study, if you power for 40 and 48%, let's for example think if you power it, then you would need 2,900 something patients, or I think more than 3,900 patients, because it's exponential. So every 10% change has such a big difference in the numbers needed to treat, let's say, or numbers needed for each group. So in that sense, yes, they have powered for based on the 86 patient study, but like everything in medicine.
Yeah. I think if your point is valid that this could have been better. They have fallen back to their 86 patient study in calculating the power side, and obviously they have calculated the 80%, and the effect size also based on that coming out to be 8%, which they have calculated. But I think they could have been better if they would have included some other studies too and taken the best figures to reach that number. So I think that's a very valid question, and that also settles the questions raised by Jayaprakash. The intention to treat analysis would have reduced the power size, is true, but again, intention to treat analysis would also help us to eliminate bias to a large extent, and so as a middle path, probably choosing ITT was not a bad option. Now, if there is any other questions, we are already run out of time, so we can take further, and if there are...
You can take closing comments from everyone. And
yeah, I will before if there are no questions, I will take closing comments, and I will start with Jitin Sharma. Yes, Jitin. Jitin is there?
Can't see his picture.
Ajit, closing comments.
So from my point of view, because there is no change in practice, I won't be going for this even for mild hypercapnia. I will go for the routine, normocapnia, maybe the lower end of normal will be my, take at this point of time. I'll go for normocapnia rather than for going for hypercapnia based on the current evidence.
Final comments from Pradeep.
Yeah, I think I stick to my previous comments, Anirban, that I think this study for me is a reflection as to we need to have a robust phase 1, phase 2 sort of a data and physiological model data to embark on such resource burdening utilization of the studies, especially conducted on humans. So ethically, I have an issue with this whole study. I'm really surprised how they got through the ethics. Honestly, I wouldn't agree for such a study through the ethics without a background data and deviating from the normal practices, which is largely accepted as a standard of care. That would be my comments.
Dr. Pandey.
I think they chose out of hospital arrest patients because I feel the ethical committee would have been a little liberal in allowing to go for hypercapnia. So, the ideal would be possibly controlled cardiac arrest resuscitation, the in-hospital. But I agree, we need more physiological questions, research questions before we take these kind of studies. But it was to my mind, it was a well-conducted study. It didn't work out their way. And Shaunak very well presented. Congratulations to you.
Friends, the TAME study came out something which was quite expected, and there was no benefit of mild hypercapnia over normocapnia improving the neurological outcomes at 6 months following out of hospital cardiac arrest in patients with shockable rhythm. However, although this study had its own limitations, some of which could have been resolved at the beginning at the investigator level, there were some which were too perplexed and which could have also introduced other problems. Therefore, from here we take on to this kind of questions that there is no difference in the neurological outcome of practicing mild hypercapnia, and that's what we practice, that's what we follow, and that's what we would continue to follow. So we will be back again on the 4th Friday with again a new study to dissect and discuss and churn out the best practice standards on the basis of the information contained and delivered by the study. Till then, from all of us of Rapid Journal Review of GICS, Shubhratri, Shabar Khayat, good night.
Thank you, Rajesh, and well done, Sonak. Greatly appreciate your effort. Really well presented, Sonak. And thanks, Rajesh, despite your busy schedule.
Thanks, everyone. Thanks for joining.
Thank you, Delhi team. Thank you, Dr. Pandey.
Thank you, Jitin. Thank you so much for your time.